Okay, so our patient is a 53-year-old male with gradual worsening for dyspnea. So his past medical history included Hodgkin lymphoma. He underwent chemotherapy, chest radiation, a second cancer later, some years ago with lobectomy for lung cancer, chemotherapy, double radiotherapy again with 1219. This was followed by pacemaker implantation, and on 2020 he had a mechanical valve in another hospital. He had the baseline creatinine of 1 with good creatinine clearance, and then the coronary angiogram, there was no severe coronary artery disease. Due to his young age, he had a low logistic Euro score, but you see the the Euro score 2 and the STS score is quite big due to the comorbidities. So this is the screen in echo with an AVA of 0.7 square millimeters with a peak of 66 and a mean gradient of 31. On top of that, he had the severe tricuspid regurgitation implicated with the pacemaker and the interaction with the pacemaker, the pacing cables. And this is the CT analysis. Of course, as Dr. Riordan said, we have to study meticulously the CT before doing any decision on patient, on the proper patient treatment. You see it's on the smallest side with an area of 335 square millimeters and a perimeter around 67, or as you can see here. And also you can appreciate the mitral aortic annulus angle, which is 31 degrees, and there's a very small distance, less than 3 millimeters, between the annulus and the mitral valve, the aortic mitral distance, which we know for the Edwards, we need to have 3 millimeters, and for core valve we need to have 4 at least. The femorals were unimpressive, maybe on the smallest sides from the right femoral, but still there are not extensive calcifications, so it's something that we can do via the transfemoral approach. So we are dealing with the young patients, and with the young patient, this is the first question that we needed to answer in the heart team, and in this format, in the grand rounds. How do you treat these patients? We know that if it's in the States, we're not going to discuss a lot. For the patients with between 65 and 80, these patients have indication for TAVI. In Europe and in Greece, more specifically, we do TAVI for patients more than 75 years old. But you know, we have quite a large database. The last few years, the last 8 years, we have done 1,400 cases. So we have 11% of these patients are less than 75 years old. And one of the patients is that came to discussion with the heart team is this patient, 55-year-old with severe comorbidities with proliferative valve 22-23 annulus, and there are many aspects how to look at it. And as Dr. Velianou said, we have to have a view to the long game. So we're talking about lifetime management. We're talking about a patient that probably it's not the best candidate for a surgical approach, and now maybe it's the first time, you know, it is the moment to discuss with the surgeons if they could do these patients, if they were happy, they would be happy to operate on this patient.
You know, there's some rules that I have for my young faculty. One is I can do a redo chest, and I can do a radiated chest, but I don't do a redo radiated chest. This guy was radiated in 1986, back when they really used to burn you, and this guy's not going to live 20 years. He's going to be lucky to live 10 years. And the STS in no way reflects what his actual risk is.
Exactly. So any other comments? Dr. Dimas?
I think the comment by Dr. Reardon says it all. Nothing to add.
So yes, so of course this is a young patient, but also, as Dr. Reardon said, this is not a patient that he has so many comorbidities, other valvulopathy as well. So we are not talking about a regular patient, a normal patient that with no other comorbidity. So we have to do a personalized decision as in all of these cases. So we discussed in the heart team of our hospital and decided to proceed, of course, with TAVR. So now we have to decide which valve to do, balloon expandable or self-expandable valve. So maybe we're in the borderline between 26 or 29 Medtronic. If we place a 26, we're going to have an oversize of 13%, and we know the recommended oversizing area is 13 to 30%. The sinus of Valsalva diameter and height, they were fine. They can the valve can be accommodated easily, and you see the LVOT dimensions are on the smallest side. So probably 26. If we were placing a Navitor, 27 would have an oversizing of 17%, so which is fine, but still we have the issue of the mitral and mitral aortic distance, which is very small, less than 3 millimeters. So also the balloon expandable valves, which is more which are better suited for young patients, because we need to have easy coronary access, as Dr. Dangas said in the previous previous session. We need to have a proper and easier access in these patients. So he's a patient that probably in the future he needs to be cathed again. So if we are dealing with the 388 area, the most probable and evident solution is to go with the 23 valve, which will approximately have an oversizing of 7%. We can also use the 20 millimeters, but then it's slightly undersized. And also at this time that we were placing the valve, we didn't have the results of the SMART trial, but we had the results of other registries, like the TAVR France registry, which showed that in the small annuli, maybe hemodynamically it's more prudent to place a self-expanding valve. As Dr. Velianou said before, and I followed his discussion, with great attention. So he said that we need to have a surgical-like approach, and this is our aim in this kind of situations. So we decided to place a balloon expandable valve, and I don't know if there's any comment from the audience, if someone would go ahead and place a self-expanding valve due to the hemodynamically superior performance. So George, what's your opinion on that?
So I think one of the most important advantages of the self-expanding valve is the fact that this is repositionable and resheathable. So you can remove the valve and you can position it in a better position, especially in this case where the aortic mitral distance is very small and the result is unpredictable with a balloon expandable valve, even in experienced hands. I think the FX will be the solution for this problem, the new technology of Medtronic platform, because it's very stable and very predictable, and you can deploy the valve at the position you want to be, and then in this case will be the ideal with a good hemodynamic profile, and even with easy, if you manage to have the commissural alignment, to have easy access to the coronaries. Any comments from the audience, from Dr. Dimas? Yes, Dr. Kilic. Can I have a microphone, please?
Hi, Yannis. I am Dr. Kilic. Very good case. Did you measure fluoroscopically also the distance between the valve and the mitral valve?
Well, Theo, nice hearing from you. No, we don't do that. We just rely on our measurements on CT before, and as you can see in the case that we are presenting, we are doing our measurements by TOE real time in the cath lab.
Sometimes CT also in different angles and different perspectives can give some errors, and the fluoroscopy between different angles also during the implantation also give very good information. And one important point also, the presence of the sigmoid left ventricular hypertrophy is present or not, because of there are publications about, you know, that watermelon effect during the implantation of the valves. But I think for fully retrievable and controlling the mechanism during the deployment, I would also prefer a self-expandable valve in this kind of very close mechanical prosthesis.
Yeah, these were very nice comments, Theo. Thank you very much. So we discussed a lot about that. So in these cases, in young patients, I'm really reluctant because despite doing our best to have a proper coronary alignment to place a supraannular self-expanding valve. So it's a young patient. So we need to have, you know, the coronary is clear of cells. So maybe the FX, as Dr. Georgiou said before, would be a solution. It's not available for us yet. And in these cases, we have also very small distance between aortic annulus and mitral. So it's maybe in self-expanding valves you need 4 millimeters. In Sapien and in maybe in my valve, I don't know, you need a little less, approximately 3. So we are dealing with 2.3 millimeters distance, and these measurements were replicated in many angulations. The main angle, you know, it's approximately 30 degrees, so it's quite favorable. So we decided to use the larger Sapien valve to have the best hemodynamic result as possible. And maybe we can proceed and then we can discuss from there. So it's this is the procedure itself. I will go quickly. It's a little bit of deviation of our protocol. So in 95% of our cases, we do light sedation, and in this case, because we were dealing with TOE as well, we decided to intubate the patient, and you can appreciate the calcification and the stenosis of the valve. So we do the normal puncture echo-guided, as we do in these situations. So I go forward. And here you can see the distance, we can make the measurement as Theo said before, but we need to pay, I think, special attention to the TOE in these cases in order to identify the place that we can land the valve. So we had information from the CT, but also from the TOE that we can relatively safe place a balloon expandable valve.
I think another advantage of the self-expanding valve is the fact that during the procedure you can estimate the impact of the valve deployment on the mechanical mitral valve. So you deploy the valve slowly. If you see that there is any interaction with the leaflets of the prosthetic mitral valve, you can pull it back and you can deploy it in a new position without interaction with the mitral valve.
Yeah, I agree, but still, George, you can see that the distance is very small. Maybe we need a little. I would feel more confident to avoid even, a delayed problem with both of the valves, with the self-expanding valve in this situation. So here you can see that there is some space to work.
So in these cases, you have to work in multiple projections in order to find the best angle you're going to use in order to have the distance, the proper distance from the aortic annulus to the mitral annulus and the mechanical valve in order to avoid any interaction.
Okay, yeah, I have to agree with that.
More LAO projections, as you showed just before that, more LAO projections showed a little bit much distance.
Yes.
Left anterior oblique, cauda,
Yeah.
LAO cauda.
Yes. Okay. So we are, when we're placing...
It was a great comment, you're absolutely right.
And Edwards, we don't normally predilate, but in this situation, we felt we should predilate in order to minimize any possible slippage of the valve, because we want to be as accurate as possible. You can see the predilation, there's a nice opening of the...
And you pace on the wire.
Yes,
Yes.
That's our practice. I think it's better pacing with a lot less complication. Especially, I think
So this is the LAO view
important.
Dr. Kilic mentioned before.
Yes, yes. And I think in this situation, when you will be really accurate, I think pacing with the wire it's even more important. So when we changed our practice and started pacing with the wire, despite a lot of course, there are many advantages in that, not only patient-wise but also economic. We managed to decrease our length of stay by 2.5 by doing by incorporating the benchmark protocol, which is very nice, and I suggest everyone, I think, to do it. Or the smart TAVR of the Medtronic, I think that there are very good options in order to optimize your procedure. Of course, this is the usual preparation of the valve, and
We're going to have the Savvy wire soon, which will be the workhorse wire, guide wire for the stiff wire for the valve deployment, and also give us some important hemodynamic information throughout the procedure.
yeah.
And pace, of course, and pacing.
It will cost, as Dr. Riordan said,
Yes.
like a shockwave, but yes, I think in the meantime, we're very happy with the Safari wire that we use in the Edward prosthesis. And in this situation, you see the TOE can help us accurately place the valve in where we want to place it. And of course, we do some tests before, and we proceed with a very, very low implantation of the valve, and by looking at the TOE as well. So we can make a small micro movements and facilitate the optimized implantation of the valve. So I think that we did was an uneventful placement of the valve, and then you can see from the cranial view as well, there is some small overlap fluoroscopically, but we don't see it in the TOE. So of course, maybe the TO has a point. We'll have to check it, from many times, but from many aspects and many regulations. But the fluoroscopy 2D imaging. So we need to rely on TOEs as well in this kind of situation. And then we measure the gradient as well.
So I think the 23 millimeter size was the proper size for the case. The 20 millimeter valve will be a small one. And I think it's an 80-20 or even 90-10 implantation, 80 to the aorta, 10 to 20 in the left ventricle, which is the ideal, very elegant implantation of the SAPIEN 3 valve.
Okay. And then we closed the access. So patient 1 month follow-up was feeling a lot better. He diminished the furosemide, maybe one tablet and the Pleranon.
What about TR?
Yes, he had a severe TR, but
any plans in the future
not do
for
anything
that?
with the patient. Wires, and actually he didn't recover from that, and actually he came back very recently. He had even more severe TR. I wouldn't say torrential, but here you see larger ERO and RV volume. So maybe there is something to be done with TR, and we know that if we use a tri-clip in these situations, we're never going to have a really good outcome. But we are investigating, we will investigate the pathophysiology. It looks cardiographically that there might be constrictive physiology as well, but patient is being implanted for a right heart and left heart catheterization, and we'll take it from there. So by concluding these cases, of course, we chose the valve that facilitates easy coronary access in the future in a young patient, 55 years old. We paid special attention to hemodynamic optimization of the procedure. We used the larger balloon expandable valve that we could use, and we tried to make as accurate implantation as possible in order to avoid any possible interaction with the mitral valve, because of there was a very, very small distance between aortic annulus and mitral valve. So in all the situations, of course, as we discussed before, we need to have personalized decision-making, which leads to better outcomes, and this have to be discussed in the grand rounds. And this simulation is very important, I think, for us, but also for the young colleagues who try to learn TAVR and how to better treat these patients. So thank you very much.
So I think this is a 50-year-old male patient with severe aortic stenosis in this age. If it's not a bicuspid aortic valve, maybe the radiotherapy was the main reason for that. And even the tricuspid regurgitation is not only for the impeachment of the leads, maybe there is some primary tricuspid valve dysfunction, and this may be estimated and clarified before you will make any thoughts to correct and to treat with a transcatheter procedure the tricuspid valve regurgitation. Thank you, Yannis. It was an excellent case, very didactic, very important for us. Any comment by Dr. Dimas?
Indeed, this was an excellent and very didactic case and very well executed. Very good analytical thoughts, the right considerations, with an excellent final result.
Any comments from the audience?
I think you choose whatever valve you want to choose. This person can die of radiation heart disease. I mean, you don't have both mitral and aortic unless you have rheumatic disease or radiation disease. This constrictive cardiomyopathy is radiation disease. They're not going to come back with coronary disease. They're going to come back with heart failure and with radiation cardiomyopathy.
Thank you for your comment.
Bad case.
So I would like to thank all of you for participating in this session, and we're going to have a break now. Thank you.